So hi everybody, I really appreciate the opportunity to come speak with you today. And as I mentioned, I did my internal medicine and geriatric medicine training here at UBC, so I recognize some of you. And I do internal medicine and geriatric medicine. And geriatric incontinence is something that is one of the geriatric giants, so to speak, and kind of is always reinforced when we go through our geriatric training. But across the country, there's kind of a dearth of training within our programs in regards to geriatric incontinence, which I think is a shame because it's a really big problem for many of our patients that we see in our clinics, and that's what kind of prompted me to go do some extra training with the only two geriatricians in Canada, in Edmonton and Montreal, who really have embraced incontinence and have done a little bit more work in that area. So today I'm going to give you a bit of a geriatric approach to urinary incontinence. I'm going to talk to you a bit about the concept of frailty and what that actually means. We often look at patients and say they're frail, but might not have an idea of what that actually means operationally. I'm going to describe the association between frailty and urinary incontinence in our population. And then I thought I would just work through two cases, a male and a female case of a patient with geriatric incontinence, to try to illustrate some of the problems that the patients we see have along with their urinary incontinence and how we might go about managing these patients. So what is frailty? So, we often use this word colloquially when we see patients. So that patient looks frail. So what does that mean? Is that just how they look? Is it how they talk? Is it how they walk in your office? What does that actually mean? And you can see these two patients here. So this gentleman with his walker, he might say he looks frail, or this little lady lying in bed that you might see in the hospital, she might look frail. But frailty actually has a definition. So frailty is really a state of increased vulnerability resulting from aging-associated decline in reserve and function. So it's not synonymous with disability or comorbidity. So for example, somebody who's disabled, so somebody in a wheelchair, might be in the Paralympics and is not at all frail. They're actually very robust. Somebody with a lot of comorbidities, for example, they may have a lot of medical problems, but they may also be robust. They might not be frail. They may still be walking. They may still be playing golf. So that person may not be frail. So these things are not the same. And we have multiple models that exist to actually try to operationally or objectively measure what frailty is. And I'm going to be talking about some of those today.
Is it always age? It says age related. Can't you be frail and not be due to age?
Usually when we think about frailty, we think about the accumulation of cellular damage, and I'll talk a little bit about that in terms of the pathophysiology. So it usually does occur in more aged people because of the accumulation of cellular damage and oxidative changes that occur with aging. So that's usually what is associated with it is aging, because our cells are getting older and there's accumulating damage within them. But I like this diagram to illustrate what frailty is. So if you look at the green line there, that's a person who's not frail. So you guys see this in hospital all the time. So an older patient will come into hospital, they'll get sick, and the green line is somebody who's not frail. So for a while when they're sick, their function will go down a little bit, but then as soon as you fix their problem, they'll come back to their baseline, they'll go home, and they'll be back to normal, and they'll go on with their day and their life. The red line is somebody who's frail. So somebody who's frail may be just kind of bordering on that independent level at home. And then they get a medical illness in hospital. They take a big nosedive and kind of go into that dependent territory. And as they get better, it takes them a lot longer to recover. And when they actually do recover, they don't return back to their baseline. And so although they're still independent, they're hovering just above that line. And the next time they get sick, they may fall below that line and become dependent. And you guys see this all the time in hospital, that somebody who comes in the hospital living alone, not requiring home supports, they get unwell and they fall below that line, into that dependent zone, and you have trouble getting them out of hospital because they can't go home the way that they were before. And when we look at the pathophysiology, and I'm sorry, this slide is a little bit small, but what we're looking at is really genetic factors and environmental factors that lead to this accumulation of cellular damage that leads to reduced physiological reserve within a number of different organ systems. So this may be in the brain, in the endocrine system, in the immune system, and we know that there's been several there's been a lot of evidence pointing to the fact that if you just have heart disease, you have really, really bad heart disease, that's going to cause you trouble. But what actually causes you more trouble is having a little bit of heart disease, a little bit of lung disease, a little bit of immune dysfunction. So small problems in each one of those organ groups will actually cause more problem than a big problem in one of those organ groups. And that really speaks to frailty and that kind of loss of homeostatic reserve as we accumulate all these problems. And that will come through later when I talk about some of the models of frailty that exist. So we develop kind of reduced physiological reserve in a bunch of different organ systems. We develop reduced physical activity, and then we become, and maybe there's some nutritional factors, we're not eating as well, leading us to become frail. When we become frail, we become more vulnerable to a stressing event, so a stressor event that happens in our life. And then we start to get things like falls, delirium, fluctuating disability, which leads to more problems with those organ systems, and you start to get it into a vicious cycle where you get more and more frail, start to fall more, start to develop more fluctuating disability, which eventually leads to increasing care needs, institutionalization, and eventually death. So in terms of models, one of the most commonly used models, and if you guys have read any of the literature looking at geriatric incontinence in frail adults, a lot of them will use the frailty phenotype to try to operationalize what frailty is. And this, because it's probably the easiest one to use, and this came from the cardiovascular health study done in the 1990s. Linda Fried is the researcher's name who looked at this model of frailty, and she looked at over 5,000 patients and followed them for 4 to 7 years in 2 different cohorts. All of the patients were over 65 years of age, and what she looked at was 5 different factors which seem to make people frail and which seem to be correlated with outcomes. So the first is weight loss. So if you're seeing a person who loses weight, I always tell my patients, I have some of these little 85-year-old ladies who come to my office, oh, I'm getting fat, doctor, I'm getting fat. I say, if you're gaining weight after you're 85, you're doing something right. That's a really good sign. Once you start to lose weight, that's when you start to worry. So weight loss is a big one. They say a loss of 4 to 5 kilograms in the past year is kind of a marker to use. Self-reported exhaustion. So just a person coming in and telling you, doctor, I'm tired all the time, I'm fatigued all the time, I have no energy. Low energy expenditures, so they use a kind of a marker of about 400 kilocalories a week for men, or about 300 for women. I mean, that's hard to operationalize, but you can say, how often do you actually leave your house? Oh, I never leave my house, I just putter around my house inside. So that's pretty low energy expenditure. Slow gait speed, so we, as in geriatrics, consider gait speed another vital sign. There's been a lot of research looking at gait speed and outcomes, and it's thought that a gait speed of less than 0.6 meters per second is very highly correlated with poor outcomes and is very highly correlated with mortality. So that's kind of the one that's the kind of cutoff that we use. And really it is different for each age group, so really it should be age stratified, but if you're looking for kind of a Gestalt number, it's 0.6 meters per second. And then the last one is weak grip strength, which really just speaks to overall strength. And they use kind of a manometer to do that, but you could just do it in your office, just kind of feeling for their grip strength. So these are all easy things that you can ask your patient about in an office setting. And that's what makes this definition kind of nice, because you can use it to kind of, you don't need to use these exact cutoffs, but you can do a gestalt to see if your patient might have some of these things. And so it was found in this study that the frailty, the presence of frailty within the cardiovascular study was about 7%. So what that means is somebody who has 0 of these things is not frail. Somebody who has 1 to 2 of these things is pre-frail, and someone who has 2 is frail. So 2 or more would be frail. And when we look at these in the study that Linda Fried did, the top line is somebody who's not frail, and the bottom line is somebody who is frail according to her definition. And within each one of these categories, the people who were frail did far worse in terms of mortality and institutionalization over the coming 72 months. And the mortality at 7 years in the non-frail group was 12%, the pre-frail group was 23%, and the frail group was 43%. So almost 50% of those frail people were dead at 72 months. And you'll notice that this doesn't include any comorbidities, it doesn't include any kind of hard medical data, it's all kind of functional data that they were looking at in this study. And those that are frail do have a very high mortality rate. Frailty, according to the phenotypical model, is also correlated with worsening mobility, falls, fractures, disability, and also institutionalization. And if you ask a lot of your older people, what are you most scared about? Death is not the one. It's loss of independence and institutionalization. So that's really what we're worried about, is maintaining quality of life and keeping people at home as long as possible. So the second one, and this is kind of a Canadian-grown frailty model that tends to be a little bit more difficult to do in practice, but if you can kind of understand the concept of it, is actually quite easy. So this is a model developed by Ken Rockwood from Dalhousie in Halifax, and this is based on the Canadian Study for Health and Aging, and he looked at over 10,000 patients and collected 92 baseline variables about these patients. So they could be symptoms the patient had, laboratory investigations, social factors, functional factors, and so basically the denominator of this equation that you see here is 92, and the number on top is the number of those 92 things that the person has wrong with them. So it's the number of things that they have wrong with them over the total number of things collected, and that makes a ratio, and that ratio is called the Frailty Index. And basically, there is a tipping point. So if you have more than if your ratio is more than 0.67, that is not compatible with life. Sorry. So if you reach a point that after your ratio gets to 0.67, you can't live because you have too many things wrong with you. And this really speaks to that kind of deficit accumulation and that loss of homeostatic reserve, because if you look at one of those things alone, so if somebody has hearing impairment, that's not going to kill you. But if you have hearing impairment and you have social isolation and you have comorbidities and once you collect too many of those things, you just can't live anymore. And of course, in clinical practice, we can't collect 92 different things, but this same model has been done just collecting 30 variables and still being quite good in terms of its validity. But even if you can think of the concept of deficit accumulation, I think that's helpful in terms of understanding frailty. And the hazard ratio with mortality as you start to collect more and more of these items is 1.57. Now, Ken Rockwood also developed, because he recognized that the Frailty Index was a bit difficult to do in clinical practice, he also made what we call the Clinical Frailty Scale. And this model is kind of nice because it comes with pictures. So you can actually see what frailty looks like. So the first patient, so the Clinical Frailty Scale number 1 is somebody who's very fit. So they're kind of your top of the line elderly person. You're like, wow, you're 80, you can do all that, that's crazy. You're still golfing, you're still maybe running. Number 2 is you're well, so you have no active disease, you have no symptoms. Number 3, you can see that person there, they have medical problems, and they're well controlled, but they're not really all that active. Once you get to number 4, you're termed vulnerable. So you're not dependent, but you have symptoms related to your diseases. So you're still kind of trucking along and being as independent as you can, but really you're starting to be limited by your medical issues and your functional issues. Number 5, you're starting to get dependent for some of your IADLs. And if any of you guys have done geriatrics, you'll know that the IADLs are more of your higher level of functioning. So your shopping, your cooking, your cleaning, your finances, your medication management. Once you get to number 6, then you're starting to be dependent for your ADLs. So that's things like bathing, dressing, feeding yourself, and transferring. 7 is severely frail, so these are probably patients who you're seeing in nursing homes, so patients who are dependent for almost everything and are very high risk of dying in the next 6 months. 8, you're kind of on death's door. And then 9 are patients, it's kind of a separate category because it's people who are not previously frail but are now terminally ill. So they might be younger patients who are close to death but were not previously frail. And although this model is fairly simple, and you could probably, assign a number to many of the patients that you're seeing in your clinic based on what you're asking them, each step up, so each number from say 1 to 2, 5 to 6, gives an increased risk of death of about 21.2% and an increased risk of institutionalization of 23.9% over 70 months. And especially when you're looking at, when you start to get into the 5, 6 range, the difference between somebody who's a 4 who's not dependent, a 5 who's starting to get dependent, and a 6 is actually quite marked. And those people probably should be thought of differently, because the death rates and the rates of institutionalization are going to be a lot higher for those patients. So what does frailty mean when we talk about incontinence? So unfortunately, there's very little work in incontinence done in the very frail. So there's very few studies out there, including patients who are in their 90s who are very frail, although many of them do have incontinence. But we do know that there is incident incontinence is associated with increased risk of global functional impairment. We know that incontinence is associated with other factors such as poor mobility, gender, so being female gender, and developing urinary tract infections. And we know that many of the geriatric conditions that we're seeing every day are associated with incontinence. So for example, dementia. You guys have all seen patients with dementia with incontinence, and we're going to talk a little bit more about that later. Parkinson's disease. So this is something that we as geriatricians are starting to see more and more of, and as you know, they develop very complex incontinence early on in their disease, which is very troubling for them, and NPH, which we also see. And I think incontinence, I was sitting next to somebody on a plane actually a couple months ago, and I just was talking to them about they were staying with their older mother at home, and she was 92, and she had been living with her daughter who was acting as her caregiver for many years. And the statement she made to me, without even knowing that I was a geriatrician or I had any interest in incontinence, she said, as soon as my mother loses control of her bladder, I'm sending her to a nursing home. That's it. That's the last straw. I've done everything for her for the last 10 years, but as soon as she gets incontinent, that's it. I can't deal with it anymore. So it's a really big issue for caregivers, and it's a really big issue with keeping people at home. And that's why one of the reasons it's so important to manage in our population. So there's certain changes that occur with normal aging that happen to the bladder. So our endothelium becomes more leaky. We develop increased elastin with a loss of the phospholipid layer. So really, when we're talking about kind of things like detrusor underactivity, or we're talking about an increased stiffness in the bladder. So there's not a loss of muscle cells, but it's more that the bladder is actually getting stiff because we're getting more elastin and we're getting less of that phospholipid layer. There's also thought to be a loss of adrenergic and dopamine receptors within the bladder, so making it less able to respond as it normally would. And just a note that when you're seeing our geriatric patients, our geriatric population is extremely heterogeneous, and that's one thing I love about geriatrics, is that I never know who's going to walk in my door. Is it going to be a little frail lady with her cane who's kind of shuffling in, or is it going to be a very robust person who's just maybe their memory is getting a little bit worse, but they're going to come in just looking like they walked off the street and they're still 30 years old. So these are some kind of more fit geriatric patients. I don't see a lot of these ones in my clinic because they're usually out enjoying themselves and not in the hospital. But this is the man in his 90s who ran the Toronto Marathon several years in a row. And these are just two ladies that I found on the net that I thought were cool, because I can't do either one of those things. So yes, our geriatric population comes in a lot of different shapes, sizes, and abilities. And early in life, a lot of us look the same. Our functional levels are the same. But as we start to get older, past adult life into older age, our range of function really splits. And I think we need to, and that's why when we're seeing our geriatric patients, it's not a one-fits-all type of solution. There may be some older people may warrant medication, for example. Some older people we might need to consider, well, is that really a good idea? They hate pills, they're really getting frail. They're on so many other medications already. So it's really not a one-fits-all. And that's why geriatrics is very individualized. And I think for some learners who come through geriatrics, some residents and some medical students, that's a bit frustrating, because we can't tell you exactly what to do for every 70-year-old or every 80-year-old, because they all look so different. So why do frail elderly people need to be treated differently? So usually, I always say this to trainees that I work with, if you say multifactorial for whatever the problem is, you'll always be right, because there's never one thing leading to the problem, it's always multiple things. So there's a higher likelihood of single treatment failure for our population. So if you just do one thing, you're unlikely to make them better, or at least all the way better, because they have a lot of different things that are leading to the particular problem that they're coming in with. And you have to consider their other comorbidities, you have to consider their functional impairments, and also their other medications, because many of the patients we're seeing are on 15, 20 different medications, and you have to consider each one of them and the interactions they might be having with the medication that you're looking at prescribing. They have more treatment emergent side effects due to age-related pharmacokinetics or age-related pharmacodynamics, and also drug-drug interactions. So with that, I'd like to just go through a few case examples with you guys, and these are patients kind of similar to ones that I've seen in the continence clinic, or in the geriatric continence clinic where I've been seeing patients recently. And so the first lady is Mrs. S. She's an 84-year-old single female. She's had urinary incontinence for the past 5 years. She lives in assisted living and mobilizes with a walker. She describes to you leakage with urgency, so a lot of trouble getting to the bathroom in time, doctor. She goes to the bathroom 10 times a day, which is very disruptive for her, because she's always having to get up from her chair at her assisted living home to go to the bathroom. She gets up 4 times a night to use the washroom, and she occasionally has some leaking with coughing. She likes her 2 cups of coffee a day and her 1 cup of tea per day. She has kind of your laundry list of different medical problems that our older patients come in with. So she has type 2 diabetes, she has hypertension, she has chronic venous insufficiency, chronic pain due to osteoarthritis in her hands and knees. She has a history of falls, some mild cognitive impairment, and she has trouble with her sleep. So her medications, she's actually not on medications. I rarely see people coming into my clinic on only 5 medications, but she's on metformin, 1 gram BID, amlodipine, 10 milligrams daily, Lasix, 20 milligrams POBID, celecoxib for her arthritis pain, and as many little old ladies that come into my clinic, she loves her lorazepam, her 0.5 milligrams of lorazepam that she's been using for many years for her sleep. So when you examine her, and really when I examine geriatric patients, the minute I ask them to come into my office from the waiting room, I'm already starting my physical exam, because one of the most important parts of the physical exam for our older people is watching how they get out of the chair in the waiting room, and how they walk into my office, and how they sit down, and also their interaction with their caregivers as they do all those things. So you notice that she has a lot of difficulty getting up from her chair. She really has to push herself up to get out of the chair. She undresses herself very slowly, and that's actually an important thing to watch, because how they undress is how they're going to be trying to get to the toilet to get their pants off to actually go toilet themselves. She has this very slow gait, which, as we mentioned, is associated with bad things in older people. Her blood pressure is 130 on 70, and it drops a bit with standing, and she gets some dizziness associated with that. She has 2+ pedal edema. Her MMSE is not bad, 26 out of 30. Her sacral innervation is intact. She has no obvious prolapse, but she has some moderate atrophy. You notice that she has very weak pelvic floor muscles, and really if you're seeing these old ladies who are quite sarcopenic, so their kind of extremities are very wasted, chances are their pelvic floor is also going to be pretty wasted, because generally they're very, very deconditioned. She has a positive stress test in the upright position. You do a PVR, it's 45 mils, and her renal function is normal. Other investigations, so her GFR is 60, her hemoglobin A1C is 9.8, and you do a urinalysis that's negative. So what type of incontinence does Mrs. S have? Here in the room, do we have any takers for urgency incontinence? Yeah, okay, good. How about stress incontinence? Great. And how about functional incontinence? Okay, perfect. So I actually think this person has all these things, and therefore this patient has what all of the older people I see have is multifactorial incontinence. So she has a bit of urgency, she has a bit of stress, and she obviously has functional incontinence. And functional incontinence really just is incontinence that has really nothing to do with the bladder. So it's the fact that she can't move very well. Maybe she has a bit of cognitive impairment, we're not really sure. And really she's quite dependent on others. So her incontinence is occurring a lot because she can't make it to the washroom in time, she can't get her pants down in time because of her osteoarthritis, and maybe she has a little bit of executive dysfunction as well. So just going through all the different things that we might think about in terms of diagnosing Mrs. S. So she does have some evidence of urgency, so some overactive bladder and urgency incontinence. You'll notice that she's on Lasix. So Lasix does make us produce more urine, and so she's getting a lot of urinary urgency and frequency, which may be related to, at least partially related to the Lasix she's on. She drinks a lot of tea, she drinks a lot of coffee, so maybe she has some polyuria related to that. And also her hemoglobin A1C is quite high, so 9.8, so she's probably having some glucoseuria that's also maybe worsening her urgency. In terms of her nocturia, so she has a lot of pedal edema, and many of the patients that we're seeing have chronic venous insufficiency, and so as soon as they lie down at night, all that fluid from their legs goes back to their bladder, and they spend all night going to the toilet. So she probably has some fluid redistribution from her pedal edema. Due to her venous insufficiency, and also a lot of drugs cause bad pedal edema in older people, and so chronic venous insufficiency, which is already causing a problem, gets worse when people are on things like NSAIDs and calcium channel blockers. If she's obese, a lot of nocturia is also associated with sleep apnea, and treating sleep apnea can help people with nocturia, so that's also something to think about. And then her enuresis. So a lot of older people are on a lot of sedatives, and especially in hospital. And if we're on sedatives, our ability to actually wake up to the stimulus that we need to void is going to be suppressed. So people who are on lorazepam, trazodone, zopiclone, any of those sleeping aids are probably going to be more likely to quote unquote wet the bed or have enuresis, which is quite distressing to a lot of our older patients. So that can be a lot of my patients. I'm trying to get off lorazepam, so that can kind of be a little bit of a motivating factor to trying to get them off the lorazepam. And also her Lasix in the presence of her pedal edema may be making her get up more at night. We know that she has functional incontinence related to arthritis and slow gait. She has some orthostatic hypotension that makes her at high risk of falls when she's going to the washroom. And then we know that she has weak pelvic floor muscles because she's kind of diffusely weak all over her body. So in terms of treatment, yes?
How do you come to the conclusion she has weak pelvic floor muscles clinically? How do you come to that conclusion?
When we do our pelvic exams, what I do is I put my finger on the pelvic floor and just ask them to kind of squeeze my finger just to get kind of a rough estimate of what their pelvic floor, how weak it is, and if they actually know how to contract the right muscles in order to contract their pelvic floor. That's what I'm basing it on, just kind of on my physical exam. So in terms of treatment, our treatments are also, obviously, if incontinence is multifactorial, our treatments are also multifactorial. So asking her to do some of the non-pharmacological things. So substituting coffee and tea with maybe some milk or some hot water with lemon, and trying to stick at around 1.5 liters of fluid per day. So maybe we want to look at discontinuing or substituting some of her medications, which can be contributing to her incontinence. So trying to get her off the Lasix. So a lot of people with chronic venous insufficiency, Lasix doesn't work all that well anyway, so maybe we could at least cut it in half. Taper her lorazepam. We could replace her NSAIDs with Tylenol. So a lot of our older patients shouldn't be on NSAIDs anyways due to the other side effects that it causes. We could look at replacing her amlodipine with an ACE inhibitor because it's also probably contributing to her pedal edema, and maybe at a lower dose because we know that she's having orthostatic hypotension, and maybe adding gliclazide to optimize her treatment for her diabetes to make her glucoseuria better. We could look at prescribing some elastic stockings, some compression stockings for her chronic venous insufficiency. We can ask her to maybe see a pelvic floor physiotherapist to do some pelvic floor muscle strengthening, and maybe a general physiotherapist to do some all-over body strengthening to try to make her better able to get to the washroom in time. We could try a trial of bladder retraining, and we can consider pharmacological treatment. And I'm not going to talk a whole lot about pharmacological treatment today. I wish I had more time. But in terms of pharmacological treatment, a lot of the geriatricians that I work with, and during my training, I was taught never use anticholinergics because they're all bad. They're all bad. I don't think that's necessarily true. I think that anticholinergics that we use for the bladder are not all made alike. I think that oxybutynin that you see at the bottom there, you see it's very highly lipophilic, it's neutrally charged, and it's a small molecule, so it's very easily crosses the blood-brain barrier. So this oxybutynin is well known to cause a lot of treatment side effects like delirium, like worse dry eyes, worse dry mouth, but we're especially worried about oxybutynin and the cognitive side effects that it can cause because of its propensity to cross the blood-brain barrier. Other newer anticholinergics like solifenacin, for example, that's lipophilic but relatively bulky molecule, tolterodine, which is again a bit more bulky, and then three of the newer ones, so trospium, darafenacin, and fesoterodine, they are less lipophilic, they're charged, they're bulky, and they also have a PGP substrate that will kick them back across the blood-brain barrier if it happens to cross. So these medications are less likely to cause some of the, especially the CNS side effects that geriatricians and we worry about so much in terms of cognitive problems and delirium. And this was a study that came out last year, the LUTS FORTA trial, and it looks at the appropriateness of treatment for lower urinary tract symptoms, specifically in older people. And I'll just kind of briefly go over the FORTA classification. So Class A are drugs that we know work well and we know are safe for our older people. Class B are drugs that have some proven efficacy, but we're still not sure about their safety. Class C, we're not sure if they work, we're not sure if they're safe. And Class D are kind of the don't use kind of drugs. And when we look, the LUTS FORTA trial was a group of experts that kind of came together to look at which drugs might fit into each one of these categories. So fesoterodine is the only one that made it into the Class B level, and that's because there was recently some trials done in a frail elderly population with fesoterodine. Catherine Dubois did a study looking at specifically frail elderly patients because there's so little research done in this population, looking at fesoterodine, looking at the fact that it does work, and looking at the fact that it didn't seem to cause any worsening cognitive problems in that population. Class C is, you have to be careful, but they can be used. So that really includes everything else, all the other anticholinergics, and also includes mirabegron. And I think mirabegron has kind of piqued the interest of many of us because it's not an anticholinergic. Now, it's still in Class C because we don't have any evidence in a frail elderly population. There has been some studies looking at specifically the trials, a meta-analysis looking at the trials of patients over the age of 65 with mirabegron, which seems to indicate that it is safe and that it does work well for that population. But we're still hopefully, and this is a relatively new drug, so we're hoping that there's going to be more trials done in frail elderly specifically. And then if you look at Class D, so don't use in the elderly, immediate release oxybutynin. And unfortunately, that's a problem in our province because oxybutynin is the only drug that's actually funded. So it's really an issue because oxybutynin is something that I would never order for any of my frail elderly patients because I think the risk of delirium, the risk of worsening cognition, the risk of falls is very high with that medication, but it's the only one that's actually covered, and I'm hoping that's going to change soon. So I'll move on to the second case. So this is a case of Mr. G, and I actually saw this man in my clinic recently. So he's an 81-year-old man. He's widowed. He lives alone, and he was living alone and was functionally independent. Unfortunately, he had been admitted about a month ago for his second myocardial infarction, which is complicated by congestive heart failure. He was admitted for a month, so he had a very long stay, and then he had to go to rehab after because he was quite deconditioned from that stay. While he was in hospital, he became, quite sad. He lost interest. When he went home, he had lost interest in playing bridge. He used to be in the bridge group, but he said, I don't really care about that anymore. I can't be bothered to play bridge. He wasn't eating very well, and he wasn't sleeping very well. His past medical history, so he has known coronary artery disease. He just had an NSTEMI, and it had one in 2011. Hypertension, dyslipidemia. He had a TIA in 2009, CHF, GERD, gout, and prostate cancer with prostatectomy in 1990. He has a long laundry list of medications, as you can see. Many people who have MIs end up on all the typical, ACE inhibitors, beta blockers, anticoagulants. And then in terms of his urinary symptoms, so he has small volume urinary incontinence. After his prostatectomy in 1990, he noticed small volume urinary incontinence just with lifting. And he went on fine for years. But then over the last 9 months, he's had urinary incontinence associated with urgency. And that's really bothersome to him because he actually has to use 4 or 5 Depends a day, and he's really sick of that. He also has nocturia, so he gets up 5 times a night to use the washroom, and that's only happened more recently with occasional enuresis. That really bothers him. He also goes to the washroom 10 times during the day. He has no hesitancy with good stream and no feelings of incomplete emptying, and he has no red flag symptoms like dysuria, hematuria. So in terms of his urinary history, he avoids fluids. So he says, I don't drink during the day because I don't want to go to the bathroom. And that's one of the common things that the older people say to me. If I know I need to go out during the day, I don't drink anything because I'm scared to death I'm going to have to go to the bathroom when I get out and I won't be able to find a bathroom. He drinks 2 beers a day. He has no other surgical history, no neurological disease. In terms of his bowel history, and in geriatrics, the bowel and the bladder are very tightly linked together. And if people's rectums are full all the time and it's pushing against their bladder's not going to be able to act very well. And I'm sure you guys see that all the time in the hospital and in the outpatient practice. But many of our older patients have dysfunctional bowels for a number of different reasons. So he goes to the washroom only about every 2 to 3 days. And we're often very good at asking, how often do you have a bowel movement? But it's actually more common in the elderly that they have really hard bowel movement. So they might go to the bathroom every day, but their bowel movements are very hard, and in that way they're constipated. He has no cognitive concerns on his part, but his MOCA score does show a score of 23 out of 30. That's a little bit lower than normal. He has no falls, but he started to use a cane since discharge. He tells me, doctor, I don't know why, but my right knee really has been hurting me since discharge, and no one's really taken a look at it. So the type of incontinence he has, again, not to belabor the point, I think he also has multifactorial incontinence. And if we think about some of the contributing factors, so Mr. G, as we know, has bad coronary artery disease, and he's had a TIA in the past. And we know that vascular disease in the brain is very highly correlated to urinary incontinence. So people with a lot of vascular comorbidities likely also have vascular problems in their brain. And we know that vascular disease tends to preferentially affect the frontal lobes first. And if you think back to your kind of early training, the frontal lobe is kind of our social center of the brain, right? It's kind of responsible for things like our social graces, our attention. If we lose those abilities in our frontal lobe, we can sometimes get disinhibited. We sometimes lose our ability to pay attention well, and it also is the place where it informs our micturition center in our brain of when it's appropriate to use the bathroom, and it helps regulate our bladder. So the frontal lobe of our brain preferentially gets affected first with vascular disease. So oftentimes vascular dementia, one of the first signs of vascular dementia is urinary incontinence. And so always remember that when you're seeing people with a bunch of vascular comorbidities, and remember to ask them about urinary incontinence, because oftentimes they will manifest with this problem. We also noticed that Mr. G was expressing some depressive symptoms, and there's a high correlation between depression and urinary incontinence in our population, and depression is also highly correlated with vascular disease such as cardiovascular disease and strokes. Diuretics and heart failure. So one kind of trick that I learned from Dr. Wegg, who I worked with in Edmonton, was that you can actually, if people are having a lot of nocturia at nighttime, you can look at giving them a dose of Lasix or moving their dose of Lasix to about 4 in the afternoon, because it's called Lasix because it takes 6 hours to start working. So if you give Lasix at 4 in the afternoon, you're able to get them to have a good micturition at about 10 p.m. at night. You might save them from waking up a lot overnight. And in practice, I've found that can be quite helpful. Other interventions for edema, which we've talked about a little bit, consider all the patient's medications, and we'll go through those. Obviously he's had a long hospitalization, he's become quite deconditioned, and now he's having knee pain, and constipation risk factors. So a lot of our older people are on calcium and iron. those are horrible medications. They cause a lot of GI upset and a lot of constipation. So some general measures for Mr. G. So in terms of fluid intake, he's limiting his fluid during the day, and we want him to be at about 1.5 liters a day, because if his bladder's not seeing enough fluid, the uroepithelium is actually an active substrate, and so if it's seeing a lot of concentrated urine, it'll actually become more overactive, and he'll actually have worsening problems. So we want him to be aiming for about 1.5 liters a day and not less. Alcohol is obviously a bladder irritant as well, so maybe he can limit his beer a little bit. We won't take it away from him completely, but maybe try to limit it as much as possible. Bladder retraining might be helpful for him. Again, pelvic floor muscle exercises also work for men, so trying to maybe get him to a pelvic floor physiotherapist. Managing his constipation, so let's get rid of his calcium, get rid of his iron, and maybe give him some PEG. And for those of you who bowel management in the elderly is very important, and kind of the most evidence-based treatment we have for elderly patients with constipation is the osmotic laxatives. So PEG and lactulose are your most effective laxatives in older people. And weight loss, always for people with stress incontinence, but I don't often tell that to older people. Comorbidities, so heart failure self-management, so get him to wear his elastic stockings, do his daily weights to make sure his CHF isn't getting worse. I actually examined his knee and he had gout in that knee, so he's on diuretics, he drinks alcohol at high risk of gout, so let's treat his gout to make his mobility better. And thinking about his cognition, so we're wondering, is this guy maybe starting to develop a bit of early dementia related to his vascular disease, which we would want to follow over time. Doing a medication review, so you notice he's on gabapentin. Gabapentin is helpful for some people with peripheral neuropathy, but again can cause really bad peripheral edema in a lot of people, especially in those with heart failure, so it's always something to think about. And also sedation, so maybe that's one of the reasons he's not waking up at nighttime to go to the bathroom. We're going to change his Lasix to 4 p.m. and maybe considering adjusting the dose downward a little bit if we want to look at making his frequency better. Treating his depression if that's something that he's interested in, and considering pharmacological therapy again for his urinary incontinence. So we're running out of time, and I'm just going to put in a bit of a shameless plug for our continence clinic. We've developed kind of a continence clinic, and I'm really interested. One of the reasons I'm here today is trying to develop some relationships with urology and urogynecology, because I think it would be really great if we could all work together to treat our older patients, because we're all seeing similar patients in our practices, and some of them may need surgery, some of them may not need surgery, some of them might be more frail, some of them might be less frail. So really we're looking at treating the really frail patients who might not be candidates for surgery for a variety of reasons, and what can we do for those patients to make them better? Because as I tried to show to you today, there's always lots that we can do to help these patients. So we're located in the Elder Care Clinic at St. Paul's Hospital on 9B. There's myself, there's Sam Leung, who's the nurse continence advisor who works with me, and she works at both MSJ and St. Paul's on a full-time basis. Joanne Savarin is a pelvic floor physiotherapist who works with us on Fridays. And then I'm very fortunate to also have a social worker, an occupational therapist, and a general physiotherapist who work with me within that clinic. So many of our older people might have social issues, they might have functional issues that could benefit from that whole multidisciplinary team that we have at the clinic. We will treat anybody, but we're really focusing on the complex elderly patients with complex medical, social, and functional issues. Patients can self-refer to our clinic. A lot of older people out there are very reluctant to go to their doctors to tell them about the fact that they're incontinent and need a referral to us, especially in the older population when they have so many other health problems and their family doctor, by the time they get to their incontinence, their family doctor is already kicking them out the door because they've already dealt with 5 other of their problems. So it's sometimes something that gets overlooked. So people can self-referral, or they can have a healthcare practitioner referral. We do outpatient work and inpatient work, and we work on both bladder and bowel. So if you have a patient, for example, with really bad constipation who's having trouble managing that, even if they don't have urinary incontinence, we're happy to see those patients as well. So who to refer, again, people with multi-morbidity, people with polypharmacy, with a lot of central acting medications, for example, people with neurodegenerative diseases who often come with a lot of other functional issues, post-stroke, poor mobility, falls, functional decline, significant bowel problems, or people with prolapse, because we do some pessary fitting at our clinic. All the patients in the clinic will see the nurse continence advisor first, and then those who fail conservative treatment or who are medically complex will immediately come to see me in addition to the nurse continence advisor. And then select patients will be referred to the pelvic floor physiotherapist or referred to other allied team members. And again, so some of the benefits of our clinic are the multidisciplinary team with all of the other allied members that we have, frequent follow-ups, so we can do about every 1 to 2 week follow-ups with our nurse continence advisor, which is helpful because some of our older patients need a lot of reminders, and also just a geriatric approach to frail patients who may not benefit or be appropriate for surgical interventions. And that's some of our information. And if you are at Providence, we have a form on SCM that you can find just under, if you type in geriatric ambulatory, and there's a little tick box for nurse continence advisor. We're actually going to change the form to say continence clinic, but for now it just says nurse continence advisor. So that's the way to refer to us. So thank you very much for having me today, and I hope you've learned a little bit about frailty and what frail patients look like. And I'm certainly happy to take any questions in the time that we have left.